A link between Alzheimer's disease and decreased visual function. What is Alzheimer's disease? Alzheimer's is the most common form of dementia, accounting for an estimated 60 to 80% of cases. Alzheimer's disease is a progressive, debilitating neurodegenerative disorder that typically occurs in the elderly. The majority of Alzheimer's disease cases are sporadic, without any known genetic mutations. Alzheimer's is considered a slowly progressive brain disease that begins well before clinical symptoms emerge. There's a characteristic loss of cholinergic cells in the basal forebrain. Neuritic plaques form throughout the brain, composed of beta-amyloid protein structures. The cortex, along with the hippocampal region, typically experience the most shrinkage and degeneration. The image on the left shows progression of Alzheimer's disease over many years. The picture on the bottom right compares a normal brain, a brain with mild cognitive impairment, and Alzheimer's disease. Note that the most degeneration occurs in the Alzheimer's brain. Who does Alzheimer's disease affect? As of 2014, 5.2 million Americans are living with Alzheimer's disease. 1 in 9 Americans over the age of 65 are believed to have Alzheimer's disease. That's 11%. Out of the 5.2 million with the disease in America, 5 million of these are 65 years or older. 3.2 million of these 5 million are women, with 1.8 being men. It's believed that the difference in prevalence between genders is largely due to longer life expectancy in women. Systemic symptoms and warning signs. Although many of the early manifestations of Alzheimer's affects the visual system, those afflicted may not notice these. Most often, other changes occur that draw attention before someone is diagnosed with the disease. Warning signs of Alzheimer's disease. Memory loss that disrupts daily life. Challenges in planning or solving problems. Difficulty completing familiar tasks. Confusion with time or place. Trouble understanding visual images and spatial relationships. New problems with words in speaking or writing. Misplacing things and losing the ability to retrace their steps. Decreased or poor judgment. Withdrawal from work or social activities. Changes in mood and personality are all signs and symptoms of Alzheimer's disease. Diagnosis of Alzheimer's disease. AD can only be confirmed technically after death upon an autopsy of the brain. Doctors use the term probable Alzheimer's dementia as a diagnosis when no other cause for the dementia can be determined. In order to diagnose Alzheimer's, doctors take a complete medical history. They note any changes in behavior and personality noted by either the individual or their family or friends. They assess their activities of daily living. They take memory tests, problem-solving tests, test their attention, counting, and language abilities, carry out standard medical tests such as blood and urine tests to identify other possible causes of the problem. Doctors also perform brain scans, including computed tomography or magnetic resonance imaging, to distinguish Alzheimer's from other possible causes for the symptoms, for example, like a stroke or a tumor. These tests may be repeated to assess Alzheimer's progression. Visual symptoms of Alzheimer's. Some research suggests Alzheimer's disease may start in a portion of the brain that integrates visual function with other areas of the visual association area. Visual function loss may be the first sign of Alzheimer's disease in an individual. These can include reduced contrast sensitivity, altered color perception, decreased motion perception, visual field defects, and difficulty with object and spatial recognition. Visual symptoms of Alzheimer's disease involving the lower visual processes. Contrast sensitivity. The majority of published studies that have investigated it have found that the contrast sensitivity of individuals is affected by Alzheimer's. Some recent work demonstrated that deficits in contrast sensitivity in Alzheimer's patients accounts for most of the differences in performance on letter identification, word reading, picture naming, and face discrimination between 35 Alzheimer's patients and 35 age-matched controls. The role of contrast sensitivity is often underestimated and under-recognized as an important visual function. Loss of contrast sensitivity was the best predictor of older patients' ability to carry out activities of daily life and can predict falling in the elderly. As the frequency of falls seems to be elevated in Alzheimer's disease patients, it may be important to test this function and adjust the patient's surroundings to prevent fall occurrences and improve their quality of life. Visual field defects. Visual field testing may be difficult, especially in advanced cases of Alzheimer's, because of the ongoing cognitive decline. An example from one study is where the authors were able to test only 55% of the patients with Alzheimer's disease with automated perimetry. Early studies describe single case reports or small series tested either by confrontational visual field testing or more often by Goldman perimetry. Various changes were found in some patients with Alzheimer's, including constriction of the visual field or homonymous deficits. For example, the 21 patients testable on the Goldman perimeter by Cronin-Golem et al. Demonstrated normal results, and the rest presented with a generalized nonspecific constriction of the visual field. These findings were confirmed later by studies involving larger numbers of patients tested by automated static perimetry. Patients with more severe dementia exhibited greater reductions in visual sensitivity. Sensitivity was reduced throughout the visual field, but deficits were most pronounced inferiorly, most commonly as ocular defects. From our current knowledge, defects in the inferior visual field could be expected, as the density of the senile plaques and neurofibrillary tangles seems to be significantly greater in the cunicle compared with the lingual gyri in the visual cortex, implying more affected inferior visual field processing area. In addition, some studies have found significant decreases in RF-NL thickness in the superior quadrant, which would correspond to a more pronounced deficit in the inferior field. This is likely an important finding with respect to the rate of falls in Alzheimer's disease, similar to the relationship found in glaucoma, where recent research demonstrated that more extensive field loss in the inferior region was associated with higher rate of falls and falls with injury. Color defects. The majority of studies suggest a definite decline in color perception among people afflicted with Alzheimer's disease compared to controls. The preponderance of studies, along with the areas of the brain affected, suggest shorter wavelength, blue-yellow, colors compared to be affected with the greatest, much like the effects of glaucoma. At this time, though, many of the published studies do not follow the same testing methods and thus make direct comparisons of data difficult. It is unknown whether much of the data suggesting a defect in color recognition and perception is affected due to lower cognitive function, or if there is an actual defect. Alternatively, electrophysiological methods could be used to test color vision objectively, but to date, no such studies have been published. Motion perception. The research on the effects on motion perception is somewhat scattered, with some research suggesting no noticeable difference between Alzheimer's patients and controls in local speed discrimination and global motion detection. Others found various deficits in motion perception, like motion detection, motion direction detection, and dissociation between a detection and perception of motion. Collectively, the conclusion of these studies is that patients with early Alzheimer's exhibit great difficulty in interpreting object motion, which worsens as the later stages of the disease come about. Higher visual processes become increasingly impaired as the disease progresses. These include reading, object recognition, spatial localization.
I will now review the suggested mechanisms for visual decline associated with Alzheimer's disease, compiled from recent broad-scale literature reviews. These include both a functional and corresponding physiological component. The three mechanisms include broadband pathway, or RNFL, glaucoma, and the optic nerve, and ventral dorsal streams and its association with the visual cortex. The broadband pathway, or precortical pathway, consists of magnocellular and parvocellular pathways. As we learned, magnocellular, which is the broadband pathway, originates with the magnocellular retinal ganglion cells. As we learned, it is responsible for higher temporal frequencies and lower spatial frequencies. The magnocellular pathway specifically shows signs of cell loss in the primary visual cortex of individuals with Alzheimer's. Imaging studies support this claim due to the increased CD ratio, or cup to disc ratio, increased cup volume, and decreased disc rim area, which is due to the loss of these retinal ganglion cells. Here are some pertinent studies supporting the broadband theory. In a 2006 study entitled Reduction of Optic Nerve Fibers in Patients with Alzheimer's Disease Identified by Laser Imaging, 40 patients with Alzheimer's disease and 50 controls had their optic nerves compared. The results indicated that there was a reduction in the number of optic nerve fibers in patients with Alzheimer's disease, with a threefold greater odds ratio for a larger optic cup-to-disc ratio in patients with Alzheimer's disease. In a second study published in 2014 called Detection of Retinal Nerve Fiber Layer Degeneration in Patients with Alzheimer's Disease using Optical Coherence Tomography, or OCT, searching for biomarkers, the study found the Cirrus OCT revealed significant RNFL thinning in patients with Alzheimer's disease, especially in the superior and inferior quadrant specifically, as well as on the Spectralis OCT revealed significant thinning in the inferior and inferiotemporal RNFL in patients with Alzheimer's disease compared with controls. These are just two of the studies pointing to a decrease in RNFL, which may be associated with Alzheimer's. Glaucoma and neurodegenerative disease. Due to the suggested increased RNFL thinning observed in Alzheimer's patients as compared to controls, it has been proposed that the neurodegeneration of the optic nerve found in Alzheimer's disease mirrors glaucoma. As we know, glaucoma is a disease of the optic nerve. As evidenced in James L. Finelli, optometrist, article in the Review of Optometry, he stated that we can think of glaucoma, a nerve disease, as also being neurodegenerative. We know that in glaucoma, retinal ganglion cells die, and the loss of these axons is seen at the optic nerve head on fundoscopy. Optic nerves losing M cells, or magnocellular cells, are degenerating, as the broadband theory suggests. Therefore, the optic nerve head takes on a glaucomatous appearance. Of note, patients with Alzheimer's disease who also have glaucoma show a course of vision loss that is much more rapid and aggressive. Both Alzheimer's disease and glaucoma are known to affect the visual pathways. Glaucoma starts in the neural tissue at the optic nerve head, as we have just discussed. However, Alzheimer's disease likely starts in the visual association areas in the cortex. Research suggests IOP in Alzheimer's disease patients may have greater diurnal fluctuations and also be less resistant to these IOP fluctuations. Support for retinal nerve fiber layer degeneration has been shown through many studies. In a recent literature review entitled Vision Function Abnormalities in Alzheimer's Disease, a meta-analysis was used to show the changes affecting patients with Alzheimer's. The table below shows retinal nerve fiber layer thickness as determined by the OCT at the optic nerve head. It shows that Alzheimer's disease subjects show thinning in various quadrants, specifically superior and inferiorly, which is also where glaucoma most often affects the optic nerve head. Of note is that no studies to date have shown correlation between optic nerve changes and extent of Alzheimer's progression. Pharmacological support can also be used to establish an association between glaucoma and Alzheimer's disease. Currently, there are 4 drugs that are used to treat Alzheimer's. Cholinesterase inhibitors, which include donepezil, galantamine, and rivastigmine, as well as NMDA receptor antagonists, which is memantine. The cholinesterase inhibitors are known to also lower IOP, or intraocular pressure of the eye, which can lead to retinal ganglion cell protection. NMDA receptor antagonists have been shown to benefit cognition, function, activities of daily living, and behavior in Alzheimer's disease patients. Treatment with memantine has been shown to slow down the progression of cell loss in the LGN, or lateral geniculate nucleus, in monkeys with glaucoma, thus evidencing that memantine may be a possible treatment for glaucoma in the future. The final proposed mechanism involves the ventral dorsal streams. The visual cortex is often increasingly affected as Alzheimer's disease progresses. Plaques, neuron degeneration, and decreased capillary flow can all contribute to the decline. Ventral and dorsal functional streams manifest certain deficits as neurofibrillary tangles and amyloid plaques impair neural transmission. Ventral deficits are part of the what pathway and can cause impaired object recognition, facial recognition, and color and pattern processing. These also manifest as low temporal frequency, contrast sensitivity defects, color vision defects, and are also supported by anatomical examination upon autopsy. This is often thought to be the most affected pathway in current research. Dorsal deficits in the where pathway can also occur and show increased decline in visuospatial processing, visual motor coordination, and motor perception. Here's a larger diagram showing the dorsal or where stream and the ventral or what stream. As you can see, the brain is very integrated, and so as neural fibrillary tangles form and plaques impair transmission, functional ability of the patient declines. Of specific interest to optometrists is posterior cortical atrophy, or PCA. It's an atypical form of Alzheimer's disease occurring in about 5 to 15% of cases, and is characterized by atrophy of the posterior cortex, which includes the occipital lobe. Selective visual and literacy decline occur due to this region of the brain being affected, while at the same time memory and language ability is often preserved in the early stages. Symptoms include visual agnosia and neglect, as well as visual hallucinations in about 25% of patients with PCA. Patients often present with decreased ability to recognize colors and shapes, as well as faces, and may have difficulty with reading and writing. Physicians diagnosing PCA must rule out stroke, tumor, and other causes that demonstrate this selective visual and literacy decline.
Purpose.
Further assessment of higher order visual function includes testing of visual memory, assessing the numerosity of complex patterns, and texture discrimination, which are all affected as the visual cortex experiences atrophy. These tests are dependent upon a complex interaction between secondary visual processing pathways and other higher cortical functions. Unfortunately, there is currently no cure for Alzheimer's. However, as mentioned before, there are currently 4 FDA-approved drugs. These are used to improve mental function, to make activities of daily living and cognition function better. However, after a certain point, the drugs are no longer effective as they cannot slow the process of neurodegeneration. Additionally, to make patients more comfortable and to maximize on quality of life, behavioral symptoms are treated. These include sleeplessness, agitation, wandering, anxiety, anger, and depression, and are often treated through other pharmacological means. To conclude the presentation, I will talk briefly about vision rehabilitation and how optometry can provide solutions for those living with Alzheimer's. It's important to remember that due to issues with visual processing and cognition, Alzheimer's patients need to start with optimum refractive error correction. Sometimes it's useful to separate the distance and reading prescriptions so that they can better maximize the use of their glasses. Additionally, it's important to address specific visual goals that the patient or their family members might have. Color can really help patients to navigate and to find items that they may need. Red is a good color to use for Alzheimer's patients, which may have deficits in their blue and violet color detection. Field defects can be addressed with prism or other methods that may be used in glaucoma treatment and therapy. Contrast can be used to make in-home modifications, such as painting a baseboard a contrasting color to the walls, which may help the person to distinguish where the walls end and the floor begin. Additionally, cataract surgery is a good recommendation for the proper candidates because it will help increase contrast sensitivity post-surgery. Finally, having well-lit rooms and quality lighting without debilitating or distracting glare is a key recommendation for all Alzheimer's patients. These are our references, and we thank you for listening to the presentation today.